morning, ladies and gentlemen. It's my great pleasure to be here today with you. It is a very inspirational conference, and I would like to thank the conference organizers, Professor Gregory Nino, and also the IBTN team for having me here this morning. It's really a unique opportunity where we can talk about cross-fertilization between the fields of behavioral medicine or non-pharmacological interventions and public health. And I work as a head of the Department of Social and Behavioral Medicine at PJ Šafárik University in Košice, Slovakia. This is the proper pronunciation. And I'm sure that you probably did not hear about this city, but it is the second largest city in Slovakia, and it is of similar size as Montpellier. And it used to be a very important city in the past. In the Austrian-Hungarian monarchy, it was in the 15th century the second most important city after the Budapest. So we were the city by king city, and it's still, you can still feel it in the architecture. Sometimes I prepare slides about Košice, but this time I did not prepare because I wanted to be, in time with my presentation. Anyway, I'm also the director of the Multidisciplinary Center for Chronic Conditions, which is a similar platform as ICEPS or ICEPS. And I'm the head of I'm the president of the section of chronic diseases at the European Public Health Association since 2006. I'm the chair of the UFA Section Council, and as Simon mentioned, also the incoming president. So now I have a 2 years preparatory period, and I will become a president in 2020. And with regard to my background, my original background is clinical psychology. So I studied clinical psychology at PJ Šafárik University in Slovakia, in Košice. And then I continued with PhD in medical sciences at the University of Groningen in the Netherlands. And I have also a postgraduate training from the University of Oxford, when I'm a member of the International Readership Program on Primary Care Research. Today I'm wearing my UFA hat. So I would like to introduce you a little bit the European Public Health Association. It is an umbrella organization for public health associations and institutes in Europe, founded in 1992. It has 81 institutional members coming from 47 countries. It is a network of more than 50,000 public health professionals, and it has 22 thematic sections, including the UFA section on chronic diseases. The vision of the European Public Health Association is to activate and facilitate a strong voice of public health in Europe. And we are trying to do that by performing high-quality research and also translating this research into policy and into practice. We are keen on capacity building. We do a lot of training and educational activities as well, and we believe in young generations, so our training and educational activities are also targeted to young public health professionals. UFA is trying to achieve its aims via the UFA tools. We are publishing the European Journal of Public Health, which is a high impact factor journal in the field of public health. We are organizing also the annual conference, which is the biggest public health event in Europe. Every year, approximately 2,000 public health professionals come to discuss about different public health topics. And on the right-hand side, you can see pictures from the last conference in Ljubljana, in Slovenia. UFA is also producing statements, reports, commenting strategic European Commission documents or WHO documents. We have been involved in several European Commission projects, and of course we try to be active also in social media. So this is our Twitter account. And this is one of the new UFA activities. We are doing that for the first time in Europe. We are organizing in May the European Public Health Week, where each day we have a theme, a specific theme to which we would like to concentrate more. So for example, on Monday we would like to, is dedicated to physical activities, Tuesday is to healthy environments, and so on. And the idea of the European Public Health Week is actually to raise awareness about the importance of public health to improve populations' health and well-being. And we are inviting national public health associations, but also other organizations who are working in the field of public health to join us and to organize activities during that week in their regions, countries, or institutions. This activity is co-organized and co-funded by the European Commission and is also supported by WHO Europe. And now I come slightly to my main topic, which is where I see the potential of behavioral medicine and public health to collaborate. And firstly, I would like to remind us or highlight the main public health challenges, our main problems of current public health in general in Europe. And definitely one of the greatest public health challenges is increase in chronic conditions, which clearly dominate both the causes of overall mortality as well as disability-adjusted life years. And on this slide, in blue color, you see chronic conditions, in green you see injuries, and in red color you see infectious diseases. So as you can see, the chronic conditions are responsible for death. We are talking here mainly about cardiovascular diseases, cancers, diabetes, and chronic respiratory diseases. With regard to disability-adjusted life years, the picture is slightly different. Also, neurological diseases or musculoskeletal conditions are coming into the picture. Why do we have such a high increase in chronic conditions? It is due to several factors. The first is population aging, and this slide illustrates the world median age is between 1960 to 2020. And as you can see, the aging populations is gradually the problem not only of high-income countries, but also is becoming a problem of middle-income countries and low-income countries as well. So in the future, everybody has to deal with this problem, more or less. And why is it so? I really like this slide by Barnett from Lancet, which shows that why aging populations is actually the problem. So at this slide, you can see that at the age of 15 years, only 10% of the population suffers from some chronic condition, but at the age of 65, it's already 80% of the population who has at least one chronic condition, but sometimes they have 2, 3, 4, even 8 chronic conditions at the same time. So population aging is on one hand a very good thing because we live longer, which is very good, but at the same time this longer living is not necessarily in good health, or to be more precise, it's not in good health at all. What are another reasons of having high increase in chronic conditions? It is the interplay between biological, behavioral, psychological and social risk factors. And these risk factors are influencing each other, are exacerbating, and are leading to one or more chronic conditions. So, for example, smoking is responsible for cardiovascular diseases, cancers, chronic kidney disease, so many chronic conditions. Or sometimes a person develops a chronic condition, and due to iatrogenic effects of treatment, he has or requires another chronic condition. So when we speak about behavioral determinants of health, we are talking obviously about unhealthy diets, smoking, alcohol consumption, physical inactivity, and it very often applies not only to us but also to other pets. And these are figures, recent figures from United Kingdom by Professor Teresa Marteau, which were published in Lancet, and they say that 16% of the population in the UK is still smoking, which is on the one hand great because it is decreasing, but still 16% is smoking. 25% consumes alcohol, which is of dangerous rate already. 65% is overweight or obese, and 95% is physically inactive. It's a striking number, but she was taking into account the recommendations of 150 minutes of vigorous activity per week, and then we all fall more or less into this category of being physically inactive. The chronic conditions have a huge socio-economic impact. Actually, everybody has to pay the price. The economies are paying the price. We are talking about reduced labor supply or sickness leaves, reduced productivity. The households and individuals are also paying the price, so premature death or decrease in quality of life of people in general. And this applies not only to patients, but also to their families and friends or people who care for them. And of course, also the healthcare systems have to pay the price. There is an increased consumption of NCD-related services. The chronic care accounts for 70 to 80% of all total healthcare costs, and also there is a great need for health systems adaptation. There is a great urgency to do something about it and to develop systems which are more efficient and work better. And I'm personally a great believer in integrated models of care, and especially the chronic care model by Wagner. It is already, it has been presented in 80s, and it's still very relevant, and it's still not really implemented. Some countries are more successful in implementing these models of care, like for example Scotland or Denmark or Netherlands, and some countries are really lagging behind. And this model says that if we want to improve the health of people with chronic conditions, we have to have productive interactions between informed and activated patients and prepared proactive team. And this model is talking about 4 system elements that are important for effective public health or effective healthcare system, and its information system. So that means electronic patient records, reminders, monitoring of the patients. Then we are talking about decision support. It means that all the decisions should be based on evidence-based guidelines, and also decisions should be made together with the patients, so not deciding about patients without them. The delivery system means that it's ideal if we have multidisciplinary teams, and for example, we have more competencies for nurses. And I would like to draw your attention to self-management, because it is especially relevant field for behavioral medicine. In chronic conditions, the patient is actually the principal caregiver, because he sees the medical doctor once, twice, 3, 4 times per year, but he has to make, or she has to make, decisions on everyday basis whether the person will take medications, whether they will adhere to treatment, you know, how they cope with everyday problems. So actually self-management support is a very important part of the care for people with chronic conditions. And just to sum up, so we've been talking about prevention. I would like to just sum up where I really see the greatest potential of behavioral medicine or non-pharmacological interventions to be involved in public health. 80% of premature heart attacks and strokes can be prevented. Similarly, 75 to 80% of type 2 diabetes can be prevented, and 40 types of cancers. So all these things can be avoided through changing health-related behavior. And when we talk about care, I just highlighted the problem of treatment adherence. 30 to 50% of patients are not adherent. So, for example, people with cardiovascular diseases stop taking medications after 1 year because they don't see the immediate benefit. And self-management support is absolutely crucial. So, this is the picture. So we see that there is an urgency to do something, and behavioral medicine scientists are doing a fantastic job in developing different interventions and different approaches how to tackle these problems. But the question is why they are not implemented more efficiently, more frequently, and in the wider scale. And I think, and now I'm talking like from the perspective of public health, these very often these are not built on very good models from the perspective of public health. They are rigid, so to speak. They are difficult to understand for public health professionals. So we are talking here about the health belief model, social learning theory, theory of reasoned action, and the stages of change model or trans-theoretical model. And all these models have limitations, have great limitations with regard to their effectiveness of predicting behavior. They are not addressing the intention-behavior gap, and they are also not addressing automatic motivation, habits, and impulsive behavior. And it is a great research done in the UK about that. And for example, there has been also a meta-analysis in this field which was evaluating these very popular theories or approaches, and it showed, this review is suggesting that intentional control of behavior is a great deal more limited than previous meta-analyses of correlational studies have indicated. So if I may quote Professor Teresa Mato, changing behavior by changing minds is unscalable. increasing inequalities and is not very effective. So actually this is the reason why the so-called old-fashioned behavioral medicine approaches are not implemented more widely in public health. So what are the new approaches? I personally like very much these approaches where instead of trying to change the minds of people to resist the environment, so it's picture number 1 when you can see all the cookies and sweet things displayed in the shops, perhaps we should change the environment. So we should put into display things which are very healthy, which are very beneficial for the patients, so to make their choices actually to be easier. Healthy choices, obviously. And this is called actually choice architecture. So it is reflected also into how we design buildings. I like very much these pictures which are motivating people to use the stairs instead of escalators. And also there are some interesting studies about transforming the foodscape. So for example, there is a study reducing salt added to takeaway foods using reduced whole salt shakers. It's a very subtle change, just if you look on the picture on the right, but it works. People are like that. And I don't have time, or I thought that I will not have enough time for going more into details, but there is a theory behind the dual process modeling, which makes very much sense, how we are, what type of beings we are. And because I'm a big fan of architecture, I have few more pictures about architecture. And I don't know whether you recognize the picture on the bottom side here. Is this conference. I'm here for the second day and I didn't really find the elevators, or I was not able to use the elevators. So I would like to congratulate the designers and architects of this building for very beautiful and very smart design. I really love it. So what are of course we have few more great publications in the field of behavioral medicine or in the field of non-pharmacological interventions. I have just few examples here, also from people who are in this room, and also another example. But unfortunately, even these good examples of behavioral medicine research or non-pharmacological interventions are not implemented in the practice. And again, the question is, why is it not happening? So what's wrong? What's wrong? We have a good research and it is still not implementing. The problem is that we are not doing knowledge translation. So it seems that scientists and politicians are living in two parallel universes. Scientists live in their ivory towers and politicians live in their political bubbles with the 4-year perspective. And somehow they don't really interact. You know, we scientists are kind of like introvertedly oriented, whereas politicians, they are just very superficial. They are just reading titles of the newspapers and they are not going into details. They don't have time for that. 2 weeks ago, we had a strategic meeting of the UFA at the Como Lake in Italy. And there was a very typical example. We invited critical friends there, so people who are not linked with UFA at all. We invited some politicians and they told us that, for example, it's really the case when they have to make important decisions in the European Commission, for example, tomorrow. What the politicians do? Just Google. What they find first is sometimes very not good quality information, fake information, for example, about anti-vaccination campaigns and so on. So it is crucial for the scientists to get more engaged with politicians. And actually what we are talking here about is the known-do gap. So there is a chasm between what is known and what gets done. The gap from research to policy and practice, and also the gap from knowledge, awareness to action and behavior change. And this problem has already been addressed by the previous WHO Director General, Dr. Yong-Wook Lee, who said that there is a gap between today's scientific advances and their application, between what we know and what's actually being done. Action without knowledge and knowledge without action means wasted resources and missed opportunities. So there is a discrepancy between what is happening in the scientific field. So on the curve, you can see the increase in scientific knowledge, scientific understanding, but somehow it is not reflected in the improved health of people. And in general, in research, it takes 17 years since the first idea when it is implemented in practice. And it is for the research which is already implemented, when you don't use the knowledge translation principles. My question is, how much of the behavioral medicine research or non-pharmacological intervention research is implemented in practice? I don't know, but I guess that not so much, which is really a pity. And also, we have some 6 common errors when we are trying to change the health behavior. And when I'm talking about we, I'm not talking, of course, about scientists, but I'm talking about the policymakers or politicians. And these 6 common errors says that, for example, first one is that it is just common sense. The second, it is about getting the message across. The third is that knowledge and information drive behavior. Fourth, people act rationally. Fifth, people act irrationally. And it is possible to predict accurately. I really love this paper. It is by Kelly and Baker, and I really recommend to read it. I will try to summarize it for you somehow. So by common sense, we mean that the idea that understanding human behavior is so obvious that it needs little or no serious thought. So this is the idea behind just common sense. But you know that if changing behavior was so simply about making just common sense, simple changes and good choices, then we all would be able to do good choices or changes for us whenever we would like to, or whatever we would like to change. But I think that everybody has this experience that it is not so easy. So if you want to change something, it is not so easy. So obviously it doesn't work. What is the second error? It is about just getting the message across. So if we only could get the message out there in some form which people could understand and identify with, then they would change in response. That's the main message of this error. But again, the psychological science demonstrates that simple stimulus response models show that there is a small fraction of human behavior which is explained by this principle. And of course, there have been in the past some successful campaigns. For example, the AIDS campaign, which used advertising as one of the tools, but I would like to highlight that it was just one of the tools. It was a very thoughtful, multi-level strategy supported by multi-pronged policies. The third myth is that knowledge and information drive behavior. So if we tell people the negative consequences of eating too much or exercising too little, they will change their behavior accordingly. Again, this is not truth. Giving people information doesn't make them change. And again, there has been some research done already in this field, for example, with young women who were supposed to eat healthy and prepare healthy food for their families. And the focus group showed that even though these young ladies know that their families and they should be eating healthy, they should eat more vegetables and fruit, there have been a host of other things in life that were getting in their way, which prevented them of doing this. And this is a very, very typical example. I heard several years ago a brilliant presentation by Leonard Syme from the United States, who said also that they developed a fantastic intervention program for quitting smoking in some populations. I don't remember anymore the details of where it has been done. And they invested a lot of money into that, energy and everything, and the outcomes were zero. They did not find any changes. And then they were curious about what happened, you know, why these people are not changing. We had this brilliant intervention program, and the reason was actually that they targeted low-income people from low-income, low socioeconomic status. So for them, it was crucial first to survive and to find things for survival and not to deal with fancy behavior change theories or interventions. Another error is that we believe that people act rationally and they do, what they know to be sensible and logical after critical and rational appraisal of the evidence. And self-interested actors obviously maximize gains and minimize costs. So this is actually the theory behind the very popular theories which I was mentioning, the theory of planned action, protection motivation, health action process approach, and stages of change theory. And as I already also mentioned, they have only a limited success So again, more examples, again some examples, smoking and dietary examples. So people want to do more physical activity, people want to quit smoking, people want to follow a proper diet, and they know, they make rational decisions about it, but again, it is not working because knowledge and its rational assessment alone do not drive behavior. So people act rationally. If people do not act rationally all the time, I think people act irrationally. So it is another error. So I said that if people do not act rationally all the time, it is also not true that always they act irrationally. So it neither is true, actually. So others people's rationality is another's irrationality. And again, there has been a study done with poor people, again, with regard to smoking, when they try to influence them. And the lady was smoking because she said that it was the only time when she could do something for herself, when she could indulge herself, when she could not work, did not have to work. So it was a perfectly rational explanation why she was still smoking, because it gave her a lot of reward. And very similar things is, I believe, in people with chronic conditions. For example, we did a study in patients with multiple sclerosis, and we found that coping strategies, avoiding coping strategies were good for them, or were kind of like promoted, because they could not accept the reality of multiple sclerosis, so they just had to hide things before themselves. So it was working for them, but even if we think that problem-solving coping strategies would be better for them. So, and the sixth error is that it is possible to predict accurately. At population level, patterns of common behavior may be observed, and the outcomes of those behavior can be seen. So, for example, in public health, we see the patterns of health inequalities. People who come from higher socioeconomic status groups, who have higher education, have in general better health. And it is a bit unclear why it is so. Perhaps they have more information, perhaps they have more money to afford better food, but this is not always the straightforward explanation. But even in the most careful models, a great deal of variance on individual outcomes remains. So even this myth, so to speak, we cannot take always seriously. So what should we do? How should we interact with policymakers? There has been, again, a great research done by some people from Canada. Jeremy Grimshaw, I had a chance to meet him last year in Montreal. I really admire him for his work in implementation research and knowledge translation. And they found that if you want to be influential, if you want to have some influence on policies, there are only two things with politicians that matter. The first is the interaction between researchers and policymakers in the context of policy networks. So, for example, you can be members of some advisory bodies, and also in the context in informal relationships. So, for example, you can play golf with them or go to some social events. And another thing is that research that matches their beliefs, values, interests, or political goals and strategies, and then you can be successful. And again, I would like to highlight the story of our critical friends from the UFA strategy meeting. One of the people who was there was a politician. She was the longest serving Ministry of Health in Italy, Beatrice Lomazzi. And she was one of the fantastic persons. She was not a typical politician. She was really collaborating with researchers, and she did a very good, she fought for a very good law with regard to vaccination in Italy. She was the longest serving Minister of Health, but because of this, she eventually lost the elections. So she was very unhappy, you know. The politicians are they really need something what they can show. Look at me, this is what I achieved within this 4-year period or less, and their only or main interest is to be again in the parliament or be again in the government. So what happened with this lady is that she created this wonderful, very good law about vaccination, and she lost the elections, so the next person who came after her changed the law. This is the reality, so it's not that easy. Nevertheless, how we can collaborate with politicians or policymakers, you can have different paths or opportunities. The first is the direct engagement. So that means that you are a member of these advisory bodies, for example, or you are kind of like on the phone, you are the consulting person for the politician. And each of these paths has its pros and cons. The positive thing about this approach is that your message, your scientific message, gets kind of like purely to the politician, so it is not distorted. What you are telling him, they can sell. The contradictory thing in this is that it is very time demanding. So the question is whether you would like to spend so much time to discussing with politicians. For example, they call you in the morning that in the evening I need some report or some statement, please do that for me, or please come to Brussels tomorrow. You know, we are not always that flexible, or do we want to be that flexible? It's a tough question. What you can do then is the so-called indirect engagement, that you collaborate with some advocacy groups, for example, with some patient organizations or professional organizations, and then you can put your message there. So they are doing the everyday job in contact with politicians and you are shaping the message. The third possibility is to engage the media. You should be writing blogs. It's not enough if the scientists are just publish papers in the academic journals. Politicians will never read them, not even policymakers. They have really problems with understanding all the research behind. So it's very helpful if we are writing blogs about them or about that, or we are informing the media. This is a great opportunity because you can have a wide reach. The con is, of course, that the message can be very distorted because the journalists can shape it according to their wills. So it is again not so simple, but you can make a choice. Or you can make another choice. I have here an example. So, for example, a member of the WHO Committee on European Advisory Committee on Health Research at the WHO Europe. So sometimes it's nice and easy if you engage with influential organizations like WHO, and again you can shape policies or politicians via contacts with the WHO people. So this is one of my final slides. I would like to urge us to break the silos between the fields of behavioral medicine and public health, because I think, as I tried to show you, that there is a great potential. So I think we should really collaborate together, and all the good science which is happening in the behavioral medicine field should be translated into public health. And perhaps the picture looks like this. There are some few attempts, but I think we should really break the silos and do the cross-fertilization, working across disciplines and so on. And in line with this, I would like to invite you to our conference, which will be in November in Marseille. The deadline for abstract submission is 1st of May, so you still have approximately 1 month to prepare your abstracts. And this year it will be also together a conference with Digital Health Europe. So again, for those who are doing some digital interventions, digital health interventions, some apps or something, perhaps it's a great opportunity. And another great thing about this conference is that it is in France. So even public health persons from France are not coming to this conference very often because of the language barrier, obviously, sometimes. But here there will be a track only in French. So even French-speaking people are very cordially invited to this conference. And I have a few more leaflets if you would be interested about the conference. And that's it. So I would like to thank you very much for the attention.